Good evening, everybody from Hamburg. It's a pleasure for me to give the Urowebinar presentation today. My name is Markus Graefen. I'm one of the surgeons from Martini Clinic. I'm urologist. Martini Clinic is a prostate cancer center at the University Hospital in Hamburg. And as I said, it's a pleasure for me to give this presentation on the role of surgery in prostate cancer. So there are about 30 minutes I'm going to talk, and then we have about 15 minutes to answer questions. And I'm very happy if you ask a lot of questions. Role of surgery, there are 5 subjects I would like to go through with you. So historically, when I started as a resident, we mainly did it in low intermediate risk disease, but it has changed, and we're going to talk about that later on. Currently, radical prostatectomy is less often performed in low risk disease, and its indication is moving more and more towards advanced disease, high risk disease, and as well oligometastatic disease. And there's some trials going on investigating the role of local treatment in this disease state. Certainly, robotic radical prostatectomy is about to be the gold standard. In many countries, it is already. In my country, it's about, I would say, 30 to 40% are done with the robot, but it's increasing. And finally, I would like to talk to you as well about the kind of future role of radical prostatectomy. As we see an aging population, an increasing life expectancy, we have to discuss where is the border of how long should we treat patients with radical prostatectomy, because the results are slightly different if we treat and operate on a young patient or on an older patient. This slide I like very much. It stems from the capture database and was published by Matt Cooperberg. It shows how the pattern of indicating radical prostatectomy has recently changed. If you look at the very left side, you see the low risk disease. And I put a green arrow on the percentage of how many patients percentage-wise underwent radical prostatectomy when they were diagnosed with low-risk disease. You see that the number is going down. And I put the red arrow on the active surveillance cohort, which means active surveillance now in low risk is more and more accepted. This goes until 2013, and we know today, these data are not yet published, but that more than half of the patients, low-risk disease patients, are doing active surveillance upfront rather than radical prostatectomy. On the other hand, if you look at intermediate and high-risk disease, again, look at the green bars and the green arrows, it's the role of radical prostatectomy is increasing, and especially if you compare to radiation in high-risk disease, it's increasing dramatically. So let's talk first about my first subject. It's the role of surgery in low and intermediate risk disease. So we know that radical prostatectomy is a very effective disease, and we have really long-term data on that. If you look, these are tons of papers looking at, for example, cancer-specific mortality at 10 years, and you see that 94 to 98% are alive with their treated prostate cancer survivors. And even after 15 years, 85 to 91% were cancer-specifically alive. So we have long-term data showing the efficacy of radical prostatectomy. And especially like when we talk long-term data, we talk about real long-term data. This is a study I like quite a lot. It stems from Johns Hopkins. It's a series of Patrick Walsh, which has now had its 30th anniversary. And you see the low-risk, intermediate, and high-risk disease, all these curves. And it's the left side, you see biochemical recurrence-free survival, you see metastasis-free survival, and you see disease-specific survival in these curves. And you see, again, even after 30 years, we have a very effective treatment with radical prostatectomy. The question that we certainly have to answer is there still a role for radical prostatectomy in low-risk disease? You probably see these patients as well with only Gleason 3 cancer, and you have to discuss it. Some patients, after counseling, opt for radical prostatectomy because they believe, and I think it's certainly kind of right, that there's a high chance of cure for good. There's a limited surgery. We don't usually take lymph nodes out in low-risk disease if a patient undergoes radical prostatectomy. That eliminates the important source for complications. And the follow-up for these patients certainly is very easy. It's just PSA. It's not like in other therapies, maybe rebiopsies or re-imaging, and there are low retreatment rates. For low-risk constellation, it is said in our guidelines, in the EU guidelines, that it has been shown in a study that in this constellation low-risk disease, the distant metastases, likelihood, and death from any cause was significantly reduced by radical prostatectomy compared to watchful waiting. And this data stems from the SBCG4 trial, a Scandinavian trial, which you're probably all aware of. In this trial, it was shown that cancer-specific survival, metastasis-free survival, and overall survival was in favor after a couple of years of follow-up for radical prostatectomy, and especially in young patients. And I put these two red arrows on the left lower side. Especially young patients benefited from radical prostatectomy in this study. So what this study showed is they looked at the median age of these patients, and if the patient was below 65, in these 800 randomized patients, the likelihood of not dying from prostate cancer was statistically significantly lower compared to the older patients who did not benefit. This slide shows you as well, you have to look at the cancer, you have to look at the treatment, but you have as well look at life expectancy of the patient to make sure that someone really benefits from this treatment. Going back to the low and intermediate risk constellation, in this SBCG4 trial, I just put the red bars and the lines around this data from Bill Axelson. It shows in both constellations a significant advantage of for deaths from any cause for patients who underwent radical prostatectomy compared to surveillance. There was some criticism of this study because it was done kind of in the pre-PSA era in Scandinavia. And therefore, sub-analyses were done. And you see, for example, that death of prostate cancer was not significantly different, even though it was slightly different in the Kaplan-Meier curves, whereas metastasis-free survival in low-risk disease was different. The other study that is very important is the PIVOT study. And as I said, the Scandinavian study was done in the pre-PSA era. Then the PIVOT study came from the United States, which was done in the PSA era. And it was questioned whether these data from Sweden could be extrapolated to nowadays way to detect prostate cancer patients. And you are aware of this data showing that there's virtually no significant difference in the deaths from any cause or deaths from prostate cancer in these patients, even with a follow-up after 15 years. And recently, a few months ago, presented on the AUA, the 20-year data were out, and again, there was no significant difference for the whole cohort. If you go a bit more into detail, and again, you should look at the risk of dying from prostate cancer, then the more aggressive the disease is, obviously, the more it makes a difference for the patient whether it's got locally treated or not. For example, if you look at PSA above 10, there was a significant difference between men observed or undergoing radical prostatectomy. The same for the intermediate risk, with the absolute risk reduction of almost 13% at 15 years. And this forest plot, again, is summarized. You see that for low-risk disease, there was no advantage for the patients, but intermediate and high risk, there was. The criticism with a PIVOT study was that many people said that the let's say, selection for these cancer patients undergoing this trial was not ideal in the way that many comorbid people were included, which is documented by the other cause mortality, deaths from any cause at 10 years, which was about 40%. So we did a study similar to the PIVOT, not a randomized trial, but looking at how many patients are alive, not dying from any other cause in a contemporary radical prostatectomy series. We put our data together with Manfred Wirth's group in Dresden, our group in Hamburg, and we found about 7% deaths from any cause in a contemporary cohort. So the criticism is, and there have been other studies showing that patient selection is very important, and the PIVOT trial does not reflect current patient selection and good patient selection. Finally, the last study that was done in a randomized fashion investigating radical prostatectomy was the PROTECT trial, published in October 2016. It's a British trial that you probably know as well, showing that in low and intermediate risk disease, there were just a very low likelihood of needing treatment, these patients, because the death rate was quite low. At 10 years, only 1%, regardless of what primary treatment was chosen, died from prostate cancer. That is the graph on the left side. If you look at the right side, you see that those patients undergoing active monitoring needed about 10 years, about half of the patients needed treatment, but still the death rate was quite low in patients conservatively managed. You have to be aware that about 3 out of 4 patients had lesion 3+3. Again, this shows that early disease does not need treatment up front. You can follow these patients and certainly treat them when it's necessary. What was shown in PROTECT as well is that the metastasis-free survival was better when upfront treatment was given. So this is an advantage of local treatment, and it was irrespective of whether the patient underwent surgery or radiation. This is, by the way, the only randomized trial where these two treatment facilities or possibilities were compared. So a lot of things have changed. As I said in the beginning, when I was a resident, we were kind of happy treating the low-risk disease. With now the achievements of PSA, we learned so much from the screening studies about overdiagnosis and overdetection that certainly our pattern of treatment has completely changed. I want to just give you one example coming from our clinic. We looked at the so-called histologically insignificant cancers, defined by the total cancer volume. There are several definitions out there. For example, Epstein, less than 0.2 cubic centimeters. This makes just 1% today of our patients. Or if you could take a more broader definition, like Wolters has done, less than 2.5 cubic centimeters. Oh, this is only about 8% of the patients we treated today. So we have a dramatic stage shift towards more advanced disease. Or another example for that, again, is coming from our clinic. Patients who have criteria for active surveillance, they only do are about 5.9% or 7.7% of contemporary patients undergoing radical prostatectomy. In other terms, we almost never operate patients who are good candidates for active surveillance today. So let's switch to another subject, and this is coming with that we learned so much about the role of treating the primary cancer, even a high-risk disease. In the earlier days, we were thinking that we might not cure the patient, but we forgot about that we dramatically alter the course of the disease of these patients when they have a high risk of dying from prostate cancer or progress from prostate cancer. So surgery was in the early years really underrepresented as a therapeutic option, but this has definitely changed. I want to show you data from the so-called MPACT database, where lots of European databases are merged, and they look specifically at high-risk disease. And if you see those Kaplan-Meier curves, you will realize that in high-risk disease treated with radical prostatectomy, about half of the patients do not have recurrence after 10 years, which shows again that's quite an effective treatment, and it's a monomodal treatment, and that is a very important issue as well, I think, for many patients. So only radical prostatectomy, no additional treatment. Half of the patients were free of survival at 10 years. One of the reasons is that we kind of often overestimate the cancer extent. So this is high-risk disease, and how many patients do have organ-confined disease? It showed around 30 to 40%. In this database, actually 44% of the patients turned out to have organ-confined disease, despite the fact that they are in the high-risk category. So something like a downstaging, which you realize once you've operated on a patient. Again, cancer-specific mortality in high-risk disease. This is MPACT database. You see that cancer-specific mortality is very low. So after 10 years, over 90% of the patients are alive, cancer-specific, and especially when the surgeon is able to take the organ out and has a specimen-confined disease. That does not necessarily mean organ-confined disease, but the specimen-confined disease. That means a negative surgical margin. Then the likelihood of dying from prostate cancer in the next 10 years is close to zero. So in bottom line, we have a decent likelihood that we cure the patient by surgery alone, yet it is recommended, and that makes a lot of sense, that you upfront inform your patients that he might be a candidate later on for a multimodal concept, which means additional radiation and maybe hormonal therapy. If you compare this with the other options we have, like radiation therapy, it's suggested in high-risk disease that you add long-term hormonal therapy. That means kind of a multimodal concept, and in T3, T4 disease as well, 3 years of hormonal therapy. So I think that might be something that is a slight advantage of radical prostatectomy, that you not in every patient need it, though you certainly have to inform the patient that he is a higher risk, that he needs additional treatment after radical prostatectomy in high-risk situation. There's been lots of retrospective comparisons about the efficacy of radiation plus hormones versus surgery. You can certainly argue that these are not the best scientific evidence, but that is what we have at the moment in time. And the studies that were investigated showed an advantage for radical prostatectomy. For example, in this study, where prostate cancer-specific mortality was the endpoint, And you see that all studies except of one favored radical prostatectomy. We have to be aware that there's certainly a selection bias behind it that we need to take into account. And there's one study going on, it's a randomized trial, SPCG15, exactly looking at this situation, high-risk disease comparing surgery and radiation plus hormones. Again, going back to our guidelines, it said the patient needs a realistic information about a substantial likelihood of additional treatment. If we look at the MPACT database, for example, the need for salvage radiation at 3 years, about 63% did not need it, and about 69% did not need salvage hormonal therapy. So there's a decent chance that a monomodal concept is sufficient for these patients. Looking at long-term complication rates and morbidity, there have been comparisons out. Again, we do not have good data on that in high-risk situation. We know from the PROTECT data that in the quality of life issues that radiation was a bit in favor towards radical prostatectomy. And in these two papers, these are retrospective analyses stemming from Canada with long-term follow-up. It was shown that the long-term sequelae of radiation therapy were higher than compared to surgery. After accounting for age, comorbidity, and so on, in all the categories that were investigated, radical prostatectomy was a bit in favor with respect to side effects in the long term. But again, I said this is retrospective studies, and we have to await the SPCG15 trial, which is ongoing and which will certainly take a couple of years until it's finished. So let me summarize. Why should we give patients surgery or suggest it or discuss it with them as one of the therapeutic options? It has a chance of cure in the monomodal setting. Certainly, the additional multimodal concept is not needed in anyone, yet you have to inform them. There might be something like a psychological advantage of those men who are downstaged. I told you that's about 25 to 44% ended up to have PT2 cancers. The urinary continence results are comparable to low and intermediate risk. There has been some studies out, certainly not the potency rates. Many of these patients are impotent afterwards. The long-term complications seem to be lower after surgery. And again, the SPCG15 trial will shed a lot of light in this situation. Lately, we just started to discuss the rationale for oligometastatic disease. Certainly, radical prostatectomy might be one of the therapeutic options in a multimodal concept, in addition to all the medication that we have these days. The resection of the primary cancer is standard in other cancers. Therefore, it was thought, why not in prostate cancer as well? It definitely will avoid local complications. I show you data for that. It might remove or will remove the source of further metastasis, which whatever consequence. And as well, it removes cells that might develop into genetically unstable disease and might therefore be of an advantage. But this is hypothesis. I will show you some retrospective data. We definitely know from some studies, just briefly show you these, that the local complications in men with oligometastatic disease, if they undergo radical prostatectomy, are prevented in quite a substantial number of men. You see, for example, Vaughan and co-workers saw a reduction of 35% of local complications, Heidenreich 9%, and a study that we did, we saw a difference of about 28% with local complications if a patient with oligometastatic disease was either treated conservatively, systemically, or in addition with radical prostatectomy. So the whole discussion started really when Kalb and co-workers in 2014 published data from the SEER database, which is on the very left lower side. What you see there is you see the cancer-specific mortality for radical prostatectomy, that's the orange bar, and you see the brachytherapy, and you see the systemic therapy, and you see that the death rate after radical prostatectomy was lower. But you have to be aware that's a highly selected patient group, and it's only hypothesis generating. So Gratzke and co-workers showed the same for the Munich Cancer Registry. You see, these are the death rates for patients, the survival curves, who underwent in the oligometastatic situation radical prostatectomy compared to any other treatment. The Prostate Cancer Registry in Sweden, upper right side, again showed a favor for radical prostatectomy and local treatment, and the same was true for the National Cancer Database. So again, I just want to emphasize this is hypothesis generating, because you have to know that if you look at all these databases, usually about 5, 6, 7% of the patients who underwent radical prostatectomy, and you certainly can assume that these are the younger patients, the fitter patients, those with a lower metastatic load, and so on, who are then being chosen to undergo radical prostatectomy in addition to the systemic treatment. Recently, we have done a study with colleagues from Copenhagen, where we try to match patients, oligometastatic disease, either treated with state-of-the-art treatment, systemic treatment, or like we did in Hamburg in a early study, systemic treatment plus radical prostatectomy. And you see that the one is on the left side, the months to castration resistance as a secondary endpoint was not different. So we thought we might change the perception of reacting to hormonal therapy by radical prostatectomy. We might prolong the interval. That was not true in this database. And the second endpoint was months to death, even though the follow-up was not that long. But at 5 years, we could not see any difference in death rates when we kind of matched these patients. So we really have to be careful not to just do it. There are randomized trials going on. I will show you. These are all the randomized trials going on investigating that. For example, the first one is at MD Anderson. It has a 3-arm study where radical prostatectomy, radiation, and systemic treatment were compared. We have here in Hamburg a trial going on, or let's say it's now Europe-wide. It's called the RAMP study, where we have now randomized 87 patients in either standard of care and standard of care plus surgery. There's an arm in Stampede that has already finished recruitment with about 2,000 patients. Again, it's standard of care versus standard of care plus radiation of the primary cancer. So this is a new field, and certainly we have to wait what these randomized trials do. I really want to emphasize that it's nothing you should do just because of this retrospective data. What's the role of lymph node dissection? This is quite another important issue. Shall we take the lymph nodes? There's clear recommendation in our guidelines. We know that it's clearly of diagnostic value. We do not really know whether it really impacts the prognosis. It might do. We have some evidence, so let's say some data that we can extrapolate with this question. Going back to the guidelines, lymph node dissection is not indicated in low-risk disease because the likelihood of harboring metastasis is so low, and there's a morbidity of lymph node dissection. In intermediate risk, we have the Briganti nomogram, and you should use this according to our guidelines. And if the risk is higher than 5%, then you should remove the node, and you should then do an extended lymph node dissection. In high-risk disease, an extended lymph node dissection is always recommended, and as well, it's emphasized that a limited lymph node dissection should not be done in a patient. We know that we will find more metastases if we do extended lymph node dissection, but as well, we know that the complication rate is certainly and influenced by that as well. So the more lymph nodes we take, the higher certainly is the complication rate. For example, from the Milan group, the lymphocyte rate was twice as high in extended versus a limited lymph node dissection. The hospital stay was longer, and the overall complication rate was twice as high extended versus limited lymph node dissection. So that's an issue going on. Again, there are randomized trials looking at that. One, for example, was just published, or let's say discussed, on the latest ASCO meeting. And it was a Brazilian study where they had 291 patients intermediate and high-risk disease. And they randomized them in extended or limited lymph node dissection with almost 3 years of follow-up. And these are the data for that. So the OR time was increased, the blood loss, transfusion rate, complication rates were higher, even though not always significant. The length of stay was longer. But surprisingly, they found no difference. That was clear, no difference in PT stage, Gleason, and margin status due to the randomization. But there was no difference in recurrence-free survival rates, radiotherapy, bone mets, or death. They took 17 versus 4 nodes out in the extended versus limited node dissection. So the likelihood of there was metastases was 6 times higher when you do extended one. But the important endpoint was not influenced by that, which I thought was quite interesting. We have a study like that going on in Germany, but it will take certainly time until we have the data. So we have no randomized trial really showing that we changed the prognosis of the patients. Certainly the goal of lymph node dissection is that we identify patients with metastatic disease. The number of nodes involved, the tumor volume, all these things are informative, and they're important for us to indicate adjuvant therapy. So I think there's clearly a role for that. Again, we might improve regional control and maybe progression-free survival. The only small study was a short follow-up. This Brazilian one I showed you did not actually confirm this, but there's a possibility for cure, which I said at the beginning, you can sometimes think about, you can kind of extrapolate retrospective data in the way that, yes, you can cure some of these people just by radical prostatectomy and lymph node dissection, despite the fact that they have lymph node metastases. And the study I like very much about this, stemming from Memorial Sloan Kettering, you see on the Kaplan-Meier curve on your upper left side that at 10 years, patients with lymph node positive disease, about 28% of these patients were cured. And especially those ones who have a very limited lymph node metastasis load were cured. You see this Kaplan-Meier curve, these are patients with 1 positive, 2 positive, 3 or more positive lymph nodes. In this area, or in this field, you can certainly cure quite a substantial number of patients just by radical prostatectomy. And as I said, it's important to know this because you're thinking about indicating adjuvant radiation therapy, for example, or any other adjuvant treatment. Again, 2 studies looking at that. This comes from the Milan group, and you see they looked in a retrospective fashion on patients with positive lymph nodes, whether they received radiation plus hormones or hormones alone. And you see that in subgroups of patients, they went better if you additionally indicate radiation therapy. And we found the same in our group here in Hamburg, that patients with positive lymph nodes who get adjuvant treatment did better when adjuvant radiation and hormones were combined compared to hormones alone. The reason why I show this to you is that there is a consequence in lymph node dissection for indicating adjuvant treatment. So it's certainly important to have this information. The big discussion that has never probably been ended, but we're involved in it on a daily basis, is what is the gold standard? Is it radical? Is it open, or is it robotic prostatectomy? More and more institutions favor robotic prostatectomy. In the United States, about 90% are done with that. Germany, I would say about 30 to 40%, but its numbers are increasing. There have been lots of studies trying to compare series. The overall complication rate, for example, of open prostatectomy was a bit higher. There was a slight favor for robotic prostatectomy. Functional outcome was looked at. Slight favor for potency rates, better potency rates after robotics. So with time, it looks like that the advantages for the robot were in the way that there was kind of convincing that many of centers changed to the robotic approach. Even though we do not have clear data in this as well, there's one randomized trial where we all waited for that actually showed on 330 men almost that there was no difference, at least in the early functional outcome and early oncological outcomes. The downside of this study, as I said, we waited all for that. The first randomized trial comparing TEF surgical techniques had the problem that there were just 2 different surgeons. One did the open, one did the robotic cases, and therefore we might just compare 2 surgeons and not really the techniques itself. And as well, the level of experience between the 2 surgeons with a respective technique was quite different. So you can use this data in whatever direction you want to interpret that. We do not have clear data today that one of the other surgical approach is very important or is better. The most important thing, and I really like this study from Andrew Vickers from Memorial, it's the surgical experience that matters most. For example, you see here the 5-year biochem recurrence rate stratified by the number of cases the surgeon has done. So whatever surgical technique you're good in, that is the one you should use. Finally, my final point is role of radical prostatectomy in elderly patients. For example, the life expectancy has been increasing dramatically lately, and we see, for example, that the life expectancy for a 65-year-old man is 17 years now. In Germany, for the healthiest 25% of men will get 90 years old in Germany today. And so we have to keep this in mind when we indicate our local treatment. So we had in Hamburg the situation that we more and more look at older patients who request local treatment We have to be careful in indicating that, and I want to show you some data on that. First of all, we see something like undertreatment in older men, and this is a study coming from the Sweden Cancer Registry, where they looked at men, almost 20,000 men under the age of 80 with high-risk disease. We know that high-risk disease really harms the life of the patient, and we all know that we should look at life expectancy. And despite the fact that more than half of the patients have a life expectancy of more than 10 years, only 10% get local treatment. That means there is an issue of undertreatment in older patients with high-risk disease. We looked at our database. We saw that this is a growing number of patients. For example, we looked at the number of patients who are 75 years or older receiving radical prostatectomy. And you see that now in the latest issue, it was about 2.7%, not a lot, but an increasing number. If you compare this to 10 years ago, it has more than doubled. The characteristic of this patient is usually they're certainly checked by their cardiologist and so on, so they're fit, they have a long life expectancy, and usually the cancer of these patients are more advanced because that is part of the patient selection. What we found in our database that the older patient, this is patients at age of 75 or older, and these are the patients younger, and you see that due to the patient selection, there's higher recurrence rates and as well metastasis-free survival was influenced in the long term. The older the patient was, the more aggressive the disease was that we treated locally, and certainly the more likely was that the patient developed metastases later on. The important issue as well is to inform the patient about functional outcome of the radical prostatectomy, because we have an excellent alternative in these older men with a combination of hormones and radiation. So to evaluate that, we looked in our database on those patients who had a higher age and looked at the influence of age on functional outcome. So we looked at continence, we looked at potency, and I want to show you this graph. This is continence 1 year after surgery, and you see down here on the axis the age, and you see that there's a clear influence. Probability of being continent is over 95% in young men, but it drops down to 85% in men reaching up to the age of 80. So between 70 and 80, you really have to talk to the patient and give him good and clear alternatives and do a careful judgment with his patients. Potency as well is dramatically dependent on the age of the patient. You see again probability of potency or ability of having intercourse 1 year after surgery, and you see that's quite high in young men, and it dramatically drops to underneath 40%. These are bilateral nerve-sparing prostatectomy patients. In old men, we have not done potency rates and so on. So old men's around really 80, but in this old man, you see it dramatically drops. So patient needs to be decently informed about that. So I want to summarize the role of radical prostatectomy in older patients. Those patients who are today seem to be eligible for radical prostatectomy are usually fit patients with long life expectancy. They usually have more advanced disease. The older age is an adverse factor for recovery of continence and potency, but still we see about 85% continence rates even in the oldest patients we operate on today. And these patients should be educated about the increased risk of incontinence and erectile dysfunction when compared to younger patients. So I'm coming to the end of my talk. I want to summarize: radical prostatectomy remains to be an important option for treatment of prostate cancer. The indication has moved towards more advanced disease. Its role in oligometastatic disease is investigated. Robotic radical prostatectomy has developed into the gold standard approach. For whatever reason, we all have all these retrospective data suggesting an advantage with especially complications and functional outcome. And radical prostatectomy is a possible therapeutic option in well-selected elderly patients. So I thank you so much for giving me the opportunity, and I'm very happy to take questions. And I think, yes, and I will start with the first question here. So the first question, that's a good one. What would be your definition of oligometastatic patient? So when we wrote this protocol, we certainly looked at what is out in the literature, and it's kind of an arbitrarily chosen thing. We started with three 3 bone metastases as oligometastatic disease. There's been some other studies, for example, the Charted study. They had oligometastatic disease up to 4 metastases. It is limited disease. So it's about 3, 4, 5 metastases is not mutually, let's say, a mutual recognized definition. But I said, yes, it's now in the study is due to the PSMA PET that is more sensitive. We accept up to 5 bone metastases as oligometastatic disease. So next question is, would you consider only imagistic criteria? I do not really get that one. I understood that if you accept only imaging, what I mean is the role of imaging has changed. For example, in Germany now the PSMA PET is a very hip thing, I would like to say, which is very sensitive. We, for example, learned when we looked at patients with oligometastatic disease that, for example, a patient with 3 bone metastases might, on a traditional bone scan, might have 5 metastases if you have a more sensitive test. That's why we actually included up to 5 metastases. And for these studies, the imaging is the most important thing, certainly. We judge whether the radiologist says this is a metastasis, we accept that. If we're in doubt, we do further imaging techniques or take a biopsy. Another question is regarding lymph node dissection. It is stated that a correct lymph node dissection cannot be done in the, I understand, extraperitoneal approach. I would disagree with that. So it's certainly more difficult, for example, if you look at laparoscopic disease, if it is, or laparoscopic surgery, if you do it with an extra peritoneal approach, it's more difficult certainly to get the lymph nodes. I think that is one of the reasons why, especially with a robot, the vast majority of people now do a transperitoneal approach, which makes it very easy really to access all the lymph nodes up to the bifurcation. So I do not think that the approach really makes a big difference. With open surgery, this is usually done extraperitoneal. Again, the lymph node yield is very high and comparable to transperitoneal approach. There was another question saying, so in low-risk disease, would you use extraperitoneal approach? You can do that. I mean, if you're familiar with the extraperitoneal approach and you have a low-risk patient where you think no lymph node dissection is necessary, there's no disadvantage to do it with the extraperitoneal approach. Next question, saying, is surgery difficult technical issues in patients who has undergone TURP before radical prostatectomy, and is there a higher risk of incontinence? Yes, that is a good question again. So the question is, TURP upfront or before, if the patient has history, does it affect our outcome? Yes, it does. There's been some studies showing that there's a slight higher incontinence rate. We found it in about 5%. There's a slightly higher impotence rate. But as well, there were studies showing that there's no influence on oncologic outcome. So we always inform the patient about this slightly lower functional outcome, but again, no difference in oncologic outcome. The next question that we got was the question of what about the indication of adjuvant radiotherapy and how long we should wait to start the adjuvant radiation in order to avoid functional outcome problems. So adjuvant radiotherapy, we have these 3 randomized trials suggesting that especially in PT3 positive margin disease, the patients benefit from adjuvant radiation therapy. We know that in these randomized trials, the control arms was never early salvage. We have the study from the Milan group comparing early salvage and adjuvant radiation showing no real difference. We have to wait for the radicals trial that is randomizing this, and until then we don't know really. But we have the guideline suggestions saying PT3 R1 disease are good candidates and should inform them about adjuvant radiation therapy. The functional outcome, it has been shown by several groups that giving the radiation after surgery certainly impairs the functional outcome. And our rule of thumb is that we wait until the patient is continent and then give the radiation therapy. If you do it while the patient is recovering from incontinence, you might clearly delay or avoid a better improvement of functional outcomes. So we rather suggest to wait and then give the radiation therapy. The next question was, do you have a fixed number for lymph nodes to be considered a good lymph node dissection? Very good. No, there's nothing like that. Certainly there's some, let's say, gut feelings. I would say like 15 to 20 lymph nodes should be taken to have a decent lymph node yield. You have to know as well that the pathologist is a very important issue as well. If you have a very thorough pathologist, you will find more lymph nodes than a less thorough pathologist. But number of 15 to 20, I would consider a good lymph node dissection. Again, there's no something like a mutual agreed cutoff. The next question I have is T3 disease, radical surgery versus radiotherapy. Good question. My position was certainly to talk about radical surgery. I could show you that that surgery is now more and more accepted to be one of the therapeutic options. But you have to tell the patient, if the patient undergoes radical prostatectomy in high-risk disease, you have to give him the information that he has a chance of about 50% that he needs additional radiation. Then you can certainly argue with the data we have now. If you give salvage radiation, you could combine it with hormonal therapy. There have been 2 randomized trials showing that there for a subset of patients is an advantage. So you have to know, you have to tell about all the consequences. I showed you the retrospective data being slightly in favor for surgery, but there's certainly a bias behind that. So let's look at the next question. What is the role of lymph node dissection in case of biochemical recurrence and diagnosed metastasis in lymph nodes? Oh, that is a new field that is coming up really in the way that we now see with the better imaging, for example, PSMA PET, that in patients with low PSA values, patients now come back and could pinpoint their metastases in a lymph node, for example. There have been a couple of retrospective studies where lymph nodes were taken out, called salvage lymph node dissection. In the majority of these patients, additional hormonal therapy was given, which certainly makes it very difficult to interpret this data. We have no randomized trial on that. We do not know really whether we really change the course of the disease, but I may say it's done quite, I wouldn't say often, but it's starting to be a little bit of a routine. So if you think about that, we're doing this once in a while in Hamburg as well. We started a program on radio-guided salvage lymph node dissection, but you have to really carefully select the patients. It should be young patients, not a lot of lymph nodes involved, slow PSA. Usually it should be, the lymph nodes should be located in the pelvis and not somewhere else. But again, it's experimental and you have to inform the patient about it. The morbidity is usually not that big, but the benefit is not yet proven. Good, so we have a couple of more minutes left and we got lots of questions. So we at some point in time have to cut off, but we take first the next one. When do you remove the urethral catheter post surgery? When do you judge continence? What measures do you advise in early, I don't know what that means. Okay, when do you remove urethral catheter post? So we usually do it on the average of 6 to 7 days. It is a bit surgeon dependent, but that is our usual rule. We do not do cystograms on a routine base, but that is certainly up to you how you do things. We have done a study whether the length of catheter, the indwelling catheter, has an impact on continence. That was not the case on the long term. On the early continence, yes, the longer the patient had the catheter, it was slightly affected the early continence rate, but after 3 months, there was no difference. So it doesn't really matter if the patient has a catheter 3 days or 10 days or 15 days. Certainly is not nice for the patient, as we all know. When do you judge continence? We and others have certainly looked at our data. The usual thing, what we do is we look after 1 month, after 1 week, and Now today, after 6 months again, that is the ICHOM criteria that is suggested, and then after 1 year, and then on a yearly basis. There's certainly a clear correlation between the time when you ask and the result. The earlier you ask, the lower are the continence rates. So we go to our last questions. I will answer another 2-1. We have really tons of questions. I'm very happy that you asked so many things. The next question is impact of surgery on quality of life in old age. Will surgery is a good option for a 75 fit male? That is what you have to discuss. I think it's clearly an individual thing you should discuss with the patient. First of all, does he really need local treatment? So we would be reluctant, and certainly low-risk disease is not a good candidate. This patient is not harmed by his cancer. Early intermediate risk, it is discussed whether these patients, all patients with low volume intermediate risk disease might be treated conservatively. If you think it's a good candidate, usually the cancer load is higher, high risk disease. But as I said, the older the patient gets, the worse are the functional outcomes. Final question I'm going to answer is, do you use nomograms for lymph node dissection, and which one? The nomogram that is suggested is the nomogram by Alberto Briganti. It looks at the risk of metastases in patients with intermediate risk disease. It's very easy to apply it. You can, if you just go to the internet and Google it, Briganti nomogram lymph nodes, you will find it. Very easy to use it. And it suggests that if there's a likelihood of higher than 5% for this patient to harbor lymph node metastasis, that you should do an extended lymph node dissection. The group has just updated it, and now they suggest a cutoff of 7%. That would spare quite a substantial number of patients lymph node dissection, but that is not yet made it to the guidelines. So the guideline recommendation today is the Briganti nomogram, higher than 5% risk of intermediate risk disease, do an extended lymph node dissection. Good. With this, I would like to finish. I thank you so much for all your interest. We have so many, we could stay here until 10 o'clock, I think, at night, but we're running out of time, and thank you very much for this. Bye-bye.